ahead and get us started. Good evening, and thank you for joining us. We've got folks registered from all over the US tonight, as well as Canada and Australia. I appreciate all of your thoughtful questions and the time that everyone is giving us tonight. We're here to talk about MS with Dr. Robert Gross. I'm Kelsey Morrow, Education Manager at the Rocky Mountain MS Center. And I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Bristol Myers Squibb and Genentech. This speaker series is just one piece of our education programming. We have a variety of formats available, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. Our most recent videos are from the Fall Education Summit. Topics there included research updates, the possibilities of CAR-T therapy, aging with MS, and managing invisible symptoms. We announce all of our education opportunities through our mailing lists, our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are free of charge to anyone interested. And now I'd like to introduce you to Dr. Robert Gross. Dr. Gross attended college at Columbia University and medical school at NYU School of Medicine. He completed an internship in internal medicine and residency in adult neurology at Brown University in Providence. He then returned to New York to complete a fellowship in MS neuroimmunology at the CGD Center for MS at Mount Sinai Hospital. Dr. Gross sees patients with MS and related disorders of the central nervous system. He divides his time between patient care, teaching, and clinical research. We did have a lot of great questions submitted at registration tonight, so we will try to get to as many of them as we can. You can continue to ask new questions by typing them into the Q&A box. Today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. And with that, I'll turn it over to Dr. Gross.
Thank you, Kelsey, for the introduction. So yes, we did receive a lot of very good questions. So I think we're probably going to end up spending most of the time just going over those. I would like to start with a few kind of basic principles that, you know, for those of you who've heard me talk before, you might have heard me say some of these things. So one, we talk about MS as an autoimmune disease, but it is more than just an autoimmune disease. So we'll be coming back to that point, I think, a few times. Two is that we also talk about MS as being a demyelinating disease, myelin being that, you know, insulating material around the surface of neurons. But it is in fact more than just that as well. It can affect other parts of the nervous system, other cells, other cell types. It can cause more widespread damage than just the myelin. And then the third thing is kind of more of a personal principle, is that, you know, we got a lot of questions today about treatments, both current and future, and especially with these kind of future, you know, experimental pipeline type treatments, I always am, you know, kind of by nature skeptical until I see actual real results in real people with MS. And so it's always good to, you know, be aware of what's kind of going on, you know, at the, you know, in the science lab, and like, you know, things that are happening in kind of early phase studies, because it can give us hope for, you know, possible, you know, major developments. But at the same time, you know, my personal take is always like, you know, show me the data, let me see actually, you know, these things working in real people. So with that, maybe we'll just go with the first question. Okay, so number one is, I have tumefactive MS, and I was curious if pain is associated with it, or is pain coming from something else? So just definition, tumefactive MS, it's not really a type of MS. It's a more of a descriptive term for MS, where there is usually one very kind of sizable lesion that looks like a tumor, hence tumefactive. But it is in essence just MS. And so, you know, we get this question actually a fair amount, you know, does MS cause pain? I guess at some point doctors were telling people that MS doesn't cause pain. And so then I've kind of felt the need to dispel that myth at various times. It can and does cause pain. Nerve pain is a common symptom in MS. But the question is, if your particular pain is coming from MS or something else, is a little bit trickier. Pain is kind of like one of these symptoms. Fatigue is another one I think we'll get to a little bit later, where a lot of things can contribute to it. And it's hard to know without knowing more about what whether your pain is specifically from the MS or not. There are a lot of treatment options for nerve or neuropathic type pain that we'll do in the clinic. We may, if it's kind of unclear, we may just like try it and see if it works. And then, if it does work, great. Or if not, or if, you're having kind of pain that's refractory to a lot of different things, we might, have to get a little bit more creative or involve other specialists and that kind of thing. But yes, certainly MS can cause pain. Okay, so number 2, it's been in the news that researchers have found sulfur-retin molecules may promote myelin repair. My further research has found that sulfur-retin has been reported in Astragalus, Microcephalus, Passiflora, Sexflora, and other organisms like lotus. And further research shows that Astragalus might make the immune system more active. This could worsen the symptoms of autoimmune diseases like MS, so it is recommended to avoid using Astragalus if you have any of these conditions. How can something that reportedly repairs myelin be contraindicated for people with MS? Good question. I think actually there's a few different questions in there. And it gets to a couple of my initial principles, actually. For one, this is obviously something that's not been fully proven yet. I think this is probably something I actually had to look this up before this talk, that some researchers are looking into as a possible repair mechanism for MS. Whether it works or not, I think it'll have to be determined by kind of more research studies, clinical research trials. Whether something makes the immune system more active and whether that certain thing is bad for MS or not, that's always, I hear that from time to time with various things, and it's always a little bit vague. The immune system is not just like a light switch that's either on or off, or a dimmer that's either higher or lower. There's a lot of different parts to it. It's quite complicated, and the parts that go awry in MS are not necessarily the parts that go awry in other conditions. Or certain treatments that affect the immune system may either be beneficial in MS, neutral, or detrimental, and it's not always easy to predict. Actually, there's a class of immune therapies called TNF inhibitors that people thought might be useful in MS, but actually it turns out that they were harmful in MS. And so sometimes it really just requires like testing it out in people to know whether something will be harmful or helpful. And that is actually the reason why we do clinical trials, in fact. So what my father-in-law used to say, he was a cancer researcher, used to say, we've cured cancer in mice 40 years ago. And the implication being like, there's a lot of things that can help, cancer, or in this case, MS in mice. Mice don't really get MS, but mice models of MS that don't necessarily translate to human beings. And so really the proof is in the pudding with a lot of this stuff. You never, like, again, back to my third principle, you never really know until you've tested it out and it's been definitively proven to be beneficial. So let's move on to number 3. Will MS be cured in my lifetime? Presently, I'm 54. I'm in good health generally. Reasonably scientific-based expectations are what I am asking for with this inquiry. Of course, I do not expect factual guarantees or unrealistic promises. I'm rational but hopeful for all. Good, because I don't want to. I'm glad that you included the caveats. You don't want to. I don't want to be like pinned down on this particular thing if I say that there is a cure or not. Well, obviously there is no cure at this moment, but I do think it's useful to kind of talk about when people say cure, what do they actually mean? Because it's not necessarily the same for every person. In some respect, I don't think a lot of people talk about cure like this, but in some respect, if you put somebody on a medication that keeps their condition, say MS, from getting worse, and they, are able to then go through life and do all the things that they want to do, and they live a kind of a full, active life for many, many years. I don't know if you would call that a cure necessarily, but managed, a condition that can be managed. And in fact, MS can be very well managed these days in many people. And so, but, most of the, I think, time people are not referring to that necessarily. Another way that people will refer to cure is like, can I have a treatment that I'll only need to take one time? It's not, kind of like this a surgical fix. Like, can I do this one thing and then never have to think about MS again, even if it maybe, there's some scar or whatever, but as long as I just like, it's like out of sight, out of mind kind of thing. And there, in a sense, there are treatments that kind of work like that, immune reconstitution therapies, things that are already available to treat MS. Alemtuzumab, cladribine are two immune therapies that are kind of like, you give it for a period of time and then done. Some people will then need to go on additional treatments down the line, although some people not. Hematopoietic stem cell transplantation is also kind of based on that principle as well. I think there's a question later on about that, and we can talk about that. But I think most people, when they're talking about cure, they're talking about like, what can be done to repair the damage that MS has inflicted upon me. When remyelinating, regenerative treatments, things that can work like that. Those are the areas. So right now, if you think about MS treatments, this is the way I kind of conceptualize things. So we've got immunotherapies, and that's like all of our disease modifying therapies currently, they're immunotherapy. So that's one bucket. You've got neuroprotective agents. So these would be things that might act on a protein or a cell type in the nervous system, in the brain and the spinal cord, that would cause it to not degenerate, that would protect it from this gradual decline that sometimes happens in MS. And then the third category and those would not be necessarily things that act more widely in the body on like immune function. Okay. And then the third category would be things like remyelinating agents, repair agents, stuff like that. So right now, at this very moment, we really only have that first category. We have things that we're thinking about for these other two categories, but we don't have anything that's really been definitively shown to work either as a non-immune based neuroprotective agent or as a remyelinating agent. And so it would be nice to have both of those things. And I think that kind of goes into when we talk about cure, like what we mean by that. And so I think we certainly have this. Hopefully we can get some neuroprotective agents soon. We can talk about some of the trials that have been done recently, especially in progressive MS, where unfortunately things like a high dose statin or what's it called, lipoic acid trial. These things that were tried in progressive MS based on earlier studies that seemed to suggest some promise in delaying progression, did not pan out in larger multi-center studies. And then for the neuroprotective agents, there have been several good ideas in recent years, and things that are currently being developed, including I think a question that is going to be coming up next. And so the future will tell. Hopefully it won't be too long, but I can't say exactly when. Question number 4, can you speak to the status and any local trials regarding PIPE 307 for myelin repair? Well, so I can speak to any local trials, which is, I don't think we are participating in a trial currently for PIPE 307. PIPE 307 is, it's a drug that is, an experimental drug that's being looked at as a way to try to promote remyelination. And it's based on the targeting of a particular receptor in the nervous system called the muscarinic M1 receptor. There was a very cool study, this maybe about 10 years ago now, that used these kind of micropillar arrays, so a bunch of test tubes, and tried to determine from this very large catalog of existing drugs which one or ones would be useful in kind of helping to promote myelination in the test tube. And so of this very large library of drugs, they identified a few that seemed pretty promising, and a couple of them, clemistine and benztropine, both kind of act on this particular receptor. And so they did more work to try to, see what this receptor does. And it turns out it helps to make the precursor cells. The oligodendrocytes are the cells in the central nervous system that produce myelin. So you have precursor cells, oligodendrocyte precursor cells, OPCs, that will grow and differentiate to become the mature oligodendrocytes. And in MS, what happens in MS plaques is that you've got these proteins and other things that are inhibiting that differentiation. And so the thought is that if you can promote that more, if you can remove those inhibitory signals, or somehow promote the OPC differentiation into mature oligodendrocytes, then you'll get more myelin production, and you'll be able to remyelinate the nerves that have been demyelinated. That's the idea. Again, proof is in the pudding, and we will see. Right now, I believe this is in early phase studies, this PIPE 307. I think there's a small study out of Australia, a phase 2 study that's looking at this. So in case people are confused about the whole phase 1, phase 2, phase 3 thing. So research takes a long time. Between the time that somebody first, figures out this might be a great idea to the time that it's available to prescribe by a doctor in clinic, it can take 10 years, give or take. So you have to go from a phase 1 trial, which is usually a very small study, usually healthy volunteers, and you're really just looking at what does the drug do in the human body, kind of thing. How is it distributed? What kind of blood levels are obtained, with different doses, and how is it excreted, and things like that. And then you move on to a phase 2 study, assuming that it doesn't kill a bunch of healthy volunteers. You move on to a phase 2 study, and that's usually in the condition of interest, MS. And it's usually, we're talking about a few dozen people. And here you're doing a little bit of dose finding still. You're trying to see what is the appropriate dose here, and you're trying to get a signal of effectiveness, right? Does the drug actually work as we want it to, as we think it will? And also safety, again, is it killing people? Is it causing, irreparable harm to this, that, or the other? And there's phase 2A, there's phase 2B. Phase 2Bs are a little larger than phase 2As, but essentially then, if things are going well and it seems like it's doing something, you move from a phase 2 study to a phase 3 study. And this is where a lot of the studies that people might be more familiar with, these are the large, like multi-center, usually in the order of hundreds to maybe over 1,000 people with MS, and they're randomly assigned usually to either the active intervention or to a placebo or to like the standard of care kind of thing. And then people are usually followed for a period of time, usually like a couple of years. And at the end of that time, the two groups are compared, and they try to see, did the drug, and people are all blinded, usually the investigators and the people who are receiving the medication, they're blinded as to their assignments. Are they getting the actual stuff, or are they getting the placebo or whatever? And at the end of the trial, you compare the two groups and you say, see, the people who received the active thing, they did much better than the people who received the placebo. Therefore, and it was safe and well tolerated. Therefore, this is a drug that we think should be available to prescribe for people with MS. They submit all their data and stuff to regulatory bodies like the US FDA. And then hopefully, in the next few months, it gets approval to be used in the clinic. And then they worry about how much it costs, and insurance companies have to put it on the formularies and all that jazz. And then it eventually, we can prescribe it and patients will get it. But all that, of course, takes a long time, and it can be frustrating for people who are hoping that hey, this is this thing that I heard about and it sounds like it's really cool. How come why can't I get on it? Well, that's why part of the reason why we like to do cutting edge research at the University of Colorado is because we want our patients to have access, earliest access possible to some of these therapies. And of course, when you're talking about a clinical trial, there's always the possibility you don't get the active stuff, and so that's part of the difference between clinical care, standard clinical care that you would get in our office, and a research trial that you might participate in. Okay, number 5, newest medication injection for PPMS. I think that's probably referring to Zenovo, which is the subcutaneous version of Ocrevus or ocrelizumab. That's made by Roche Genentech. It's been around it's been available only like a couple months, I think. It seems like it does the same thing. So it's just an anti-B cell therapy like Ocrevus. It's just the route of administration is a little bit different. It's a subcutaneous injection as opposed to an IV infusion. We're still trying to figure out the best way to give it to people. And so even though it's a subcutaneous injection, right now it seems like it's really only going to be limited to infusion centers, because you have to have somebody give it to you and then kind of watch you. It comes in it's like a liquid. I want to say it's like 23 milliliters or something like that, and then it gets injected like into the belly subcutaneously, and there's like this bubble that forms, and then they have to watch you for a certain period of time. So there's pre-medications and then the observation period afterwards. So the idea is hopefully it'll be a little bit less cumbersome than an IV infusion like Ocrevus is. I don't know, because I haven't really had any patients on it yet, because it's really so new. But I don't expect that it would work any better than your traditional ocrelizumab, but it might be a little bit faster. And I'm not entirely sure how long. I assume the bubble will kind of recede pretty quickly, but I'm not entirely sure if there's a concern about the aesthetics of it or whatever. And for people who may be experiencing like infusion related reactions because the medicine is going directly into their vein, the traditional ocrelizumab, then perhaps this would be a reasonable option. There's also Kesimpta, which is made by a different company, or ofatumumab, which is another anti-B cell subcutaneous therapy. That's one that's only given once a month on average, except for the first loading doses. And so that one actually is administered by you at home. So that sometimes people get those two confused. They're both pretty new. I have several patients on Kesimpta that seem to be tolerating it pretty well. And so, yeah. Number 6, do you feel DMTs for progressive MS after 70 years for someone who has never had the opportunity to take any other DMTs, and then in parentheses diagnosed in 1979, is beneficial? Hard to say. We talk a lot about age. It's actually been a lot on my mind lately, aging with MS, and how should we be best treating folks with MS, particularly older people. In a nutshell, the basic concept is that MS, it's a kind of a lifelong condition, or a chronic condition over many, many years, but doesn't necessarily act the same way over all that time. Early on, there's typically a lot more of the kind of overt inflammation, like we can see with sudden changes or relapses that people can have clinically, or on their MRIs when we see new lesions forming, or lesions that take up the contrast gadolinium enhancing lesions on their MRIs. And so those kind of things tell us that there's a lot of this kind of overt inflammatory activity that we think is driven by invading immune cells, and this kind of autoimmune process that kind of predominates early on in the condition. that process, that part of MS, and this goes back to, I think, my first principle, that part of MS is the autoimmune part is we have a decent handle on that. Our treatments pretty much all target that part of things, whether it's an anti-B cell therapy or a fumarate or an S1P like fingolimod or siponimod or whatever. We think all of our currently existing disease-modifying therapies are in some way, shape, or form targeting immune processes and preventing that part of things from happening. There's this other part, what I'll call like a neurodegenerative part, that we don't have as good of a handle on. And we have some things, mostly imaging, newer kind of imaging things that may correlate to a certain extent with it. But in large part, it's just something that we see happen in some people as a gradual decline over months to years, where a lot of things like their traditional MRI metrics are not showing us active disease. And a lot of our drugs don't do a whole lot for that. So we really only have these category 1 immunotherapies. We don't have these other types of neuroprotective agents that might be slowing down that process or those processes. And so we think that, not knowing anything else about you except that you had progressive MS and you're diagnosed in 1979 and you're 70, the odds are is that part of things is probably the predominant process, biologically speaking, that's happening in you. And so it's likely that you with our current kind of class of treatments, that you're probably not going to benefit all that much. I do have a few people in their 70s on disease modifying therapy, so it's not like there's a firm number where I'm just like, nah, let's not do that. And of course, it's a different kind of conversation to have somebody who's already on something versus somebody coming to you for an opinion. Do you think I should start this thing and continue taking it for years and years? So I mean, I would say based on what you're telling me now, probably not that beneficial. But I'd like to know more, especially like, have you had any recent relapses and have you had any recent activity on MRIs, any new lesions, any active lesions? How do you choose between, this is question 7, how do you choose between B cell therapies? Are there any specific advantages to one over another? Okay, good. So B cell therapies we like to talk a lot about at our center. We're very anti-B cell therapy happy. We prescribe a lot of different MS medications, but we do use a lot of the B cell therapies lately. I mentioned a few of them already. There's 4 currently available. There's rituximab or Rituxan is the brand name. There's ocrelizumab or Ocrevus. There's ofatumumab or Kesimpta. And there's ublituximab or Briumvi. All of them are IV infusions except for the third one, ofatumumab or Kesimpta, which, as I mentioned, is a subcutaneous injection, usually given once a month. How do I decide between them? Honestly, most of the time it's a question of just what do I think the patient's going to have access to? What do I think their insurance is going to authorize, quickly? Because medically, scientifically, I think they're all pretty similar. They're all doing pretty much the same thing in the body. There may be some differences, as I mentioned, between, tolerability, if you're getting something through an IV versus if you're getting something through a subcutaneous injection, possible. With all of our IV infusions, we've seen, in some people, there's, usually mild type infusion reactions. It doesn't really seem to be like more or less with one or another. There's with I mentioned kind of timing, like how long it takes. With the newest one, Briumvi or ublituximab, that they say that the infusions are only supposed to be an hour. With Ocrevus, we are often doing a more rapid protocol, but that still ends up taking a couple hours to do. And similarly with rituximab or Rituxan, which we will still prescribe. It's an off-label thing, so it's not FDA approved to treat MS, but we'll sometimes use it in some people. And we'll, for people who have been on it for a long time, we may do a more rapid protocol as well, but it still might take a few hours. And so, how long it takes, the side effects, whether you experience any infusion reactions or immediate reactions related to the medication may vary between one or another. But again, kind of in terms of how effective they are, they're all very effective, especially in the early stages and in the relapsing MS. Nothing, again, is all that effective later on and in the progressive stages of MS, although we may try one or another. There's some suggestion, I almost hesitate to say it, but there's maybe some suggestion that with some of the kind of safety monitoring that we do with these medications, where we're checking how much antibodies are being produced or immunoglobulins are being produced by your body, that the subcutaneous, the Kesimpta may cause a little bit less in one of those complications of those numbers kind of starting to decline, which if you have antibody levels that are declining and declining and declining, if they got to a really low level, that can potentially, cause an issue and make you more susceptible to infection. So it's obviously something we like to monitor. And I haven't seen as much of that with Kesimpta. It hasn't been out that long, and they had there was a major caveat with their clinical trials, which was that if they started to see people's numbers dropping, then they kicked them out of the study. So we don't really have good long-term data on what happens with that. I just haven't seen it in the few patients that I have on it. I haven't seen it as much as I've seen it with some of these other medications. But that aside, I think they're all, again, pretty similar. And so it's whatever your insurance wants. No, I mean, we try to get the best medicine for you, but sometimes it really is a discussion about, like, which one do we think we can get our hands on quickest. I'm interested in learning what is suggested for people living with MS. Question 8. Great question. So pretty broad. I think, so generally speaking, it's a good idea to have a good relationship with your doctors. And I say doctors, not just your MS neurologist, but also your primary care doctor. A lot of people, they might think MS is really their only problem, so why do they need to have a primary doc? But I think it's a good idea because you never know what might come up, and sometimes you might need referrals to other specialists or things like that. And it's always good to have somebody else who knows you and that you have a good relationship with. Kind of very common sense type things. We talk a lot about just getting regular physical activity to the extent that you can, eating a healthy diet, kind of to a certain extent how you choose to define that. I mean, trying to avoid, lots of processed foods, I think, is probably a good idea. Trying to avoid, like a lot of like desserts and salty things usually probably is a good idea. Fruits and veggies, that kind of thing. There's not like one particular diet that I tend to recommend, although, if you had to pin me down, maybe something in the kind of Mediterranean space. But honestly, it's something that you're comfortable with, that you can stick with. So something like that. And then, the regular physical activity. Good sleep is so important. And I think a lot is very neglected. And so, that means trying not to be staring at a screen like when it's really bedtime. So we talk about sleep hygiene a lot. Establishing a routine where you're kind of going to bed every night pretty much at the same time, and you're using the bedroom mostly just for kind of sleep related activities. You're not doing a lot of work in bed and other kind of things that are going to keep you awake. Paying attention to your happiness, your mental health, I think that's often another thing that people neglect. So just trying to do things, carve out time in the day. It might be a busy day, it might be a busy week, but carve out time for yourself, things like that. So that's not necessarily specific to MS, a lot of these things that I'm mentioning, but it's just a good idea, to lead kind of a healthy, active lifestyle and try your best to, be happy. And then, you follow with your doctor. Hopefully you have a good one that you trust, and, hopefully you're taking their advice. And really that's kind of the main things that I focus on. If you can do all those things, you're usually in pretty good shape.
Dr. Gross, we did have a diet question while you're on this subject.
Okay, sure.
They said they know there's many different diets out there, but very little clinical proof on their relationship to MS. The question is about dairy. Can dairy exacerbate MS symptoms?
Good. I'm glad you brought that up. I know there's a lot out there on, again, kind of very particular diets, and some of these things you might read about are, I think very restrictive. Like, you cannot eat this whole category of food. You can never eat this category of food. And for me, I don't think that it's necessarily been proven that that's good advice for all people with MS. If it were me, if I had MS, I wouldn't cut out dairy. I wouldn't, because I enjoy, occasional ice cream, and that's okay. If that's what you enjoy, that's okay. Now it's a different thing if you have, if you're lactose intolerant, or, if we're talking about gluten and you have a clear gluten, sensitivity, like, yeah, don't eat that stuff. But just because you have MS, I don't know that you necessarily need to cut out those things. I think if you can stick to the basics of what I was just, talking about before, that should be pretty good for most people. Cool. Okay, moving on. In the MS Education Summit, one of the presenters mentioned that men with low testosterone levels might have higher MS rates. My question is, should men with MS have their levels checked? If they should and it's low, should they do anything? Good question. I guess the answer to the first question is, yeah, probably should be checked. Especially if they're experiencing things like fatigue, lower libido, things like that, then yeah, it might be a good idea to have that checked. And then if it's low, should they do anything? Well, yeah, should probably be supplemented. Now, usually MS neurologists, as far as I'm aware, are not the ones that are prescribing testosterone supplementation. So I think it's kind of like, other hormones, like, a thyroid or whatever. If it's, detected to be low, you might get thyroid supplements from like your primary doc or from an endocrinologist. And so I think it'd probably be a similar thing with testosterone, but it's good. And I should make a mental note of that we probably should be checking it more than we are. I mean, obviously there's also, lots of things that are connected, on a group level or population level to being more likely to have MS. Doesn't necessarily mean that like every man with MS has low testosterone. So just to clear that up. Question 10. Are the newest meds available 100% safe, or do they shorten the lifespan if the patient do probable harm to certain main organs? Well, no medication is 100% safe. If it's 100% safe, then it probably doesn't work. I mean, that's the God's honest truth. I mean, there's like every medicine that is prescribed, there's always at least, the possibility for a side effect. The side effect might be mild, self-limited, whatever, but, pretty much all medicines, even, over-the-counter things, have the potential for side effects. Now, that doesn't necessarily mean that you will get that side effect. I know I talk to a lot of people, and I, do a lot of kind of counseling about, well, these are the potential side effects that go along with this medication. And then some people will come away from that being like, oh, I'm definitely going to get that. That's what I'm going to get, because I get everything, so I'm going to get that thing. But the reality is that a lot of these things are very rare. They're listed on, a package insert, or as, they're in the, the fast talking part at the end of the commercial. But it's really just because maybe one person who's taken that medication reported that thing, and it may or may not be connected to to it. So there are some side effects that we know of that are more common with certain medications, certain classes of medications, and so we look out for those more. And then, of course, the ones that are more serious, we're going to be paying more attention to those things. And with a lot of our disease modifying therapies, because they're based on kind of manipulating the immune system, we're looking out to see whether we're causing we're lowering your defenses, your ability to fight off infection. And so a lot of our kind of monitoring is about that, and a lot of our questions should be about, are you getting sick more than you otherwise would? Are you having more difficulty recovering from infections? Are you having, serious infections that land you in the hospital? Things like that. So if your doctor is not talking to you about that, you should maybe volunteer those things, because it is helpful to know whether we've overshot the mark. So, but, again, just because, shorten the lifespan, I mean, we hope that our medications are not shortening your lifespan. Otherwise, we would really not be prescribing them. And so our goal is really, as doctors, obviously, first do no harm. Or if there is the possibility of harm, then hopefully the possibility for benefit far outweighs that possibility for harm. So we are always trying to kind of balance those two things, what we think the benefit is and what we think the potential risk or harm might be. And ideally, with most of these medications that we're prescribing, the benefits would far outweigh the risks, right? And it can be a running conversation. Like, it doesn't have to be, we prescribe a medication. We want to see you again. We want to know how you did with that medication. Did you have any side effects? If you did, are they continuing or did they kind of go away? All of those things are good to know, because then it helps us know whether we should continue to prescribe it or not. Okay. Number 11, contrast versus no contrast. What's the difference? Okay, so this question is referring to the contrast that we sometimes use in MRIs, which is a material called gadolinium, or there's different gadolinium type products available. The difference is that traditionally we'll use gadolinium when we're trying to see if an MS lesion is active. An active lesion will take up the contrast. So you get the contrast injected into your veins, and then they'll take a bunch of pictures of your head, and you'll see the contrast kind of going into the blood vessels that are kind of surrounding the brain. And then if there's an active lesion, it'll kind of leak into the substance of the brain, into that lesion. And it'll show on this particular sequence, usually it'll be the only thing that'll be bright. And then that'll tell us that lesion is active. And usually an active lesion will stay active for a few weeks, and then it'll kind of fade away. That can be useful, especially when we're trying to determine certain things like, does a person need to be on treatment? Like, if they're not on treatment, do they need to be on treatment? Well, let's check their MRI and see, are they having active lesions? And it can be helpful, especially if they've got a lot of old lesions. Old lesions we detect on a different sequence, usually called a flare sequence. And sometimes if they've got a lot of them, trying to just see, is there one new one? If you've got a bunch of them here and a bunch of them on this, on the old scan, on the new scan, trying to tell whether there's one that's new compared to this old scan can be a little tricky. But like I said, when you do the contrast study, usually all of those old ones just kind of disappear, and you only see the ones that are active at that moment. And so it can be much easier to detect. For routine surveillance MRIs, oftentimes we are avoiding the contrast. And that's because a few years back, they started noticing that when you did tests of people who had gadolinium in their life, from successive MRI scans, that the gadolinium sticks around in the brain longer than we thought it did. It hasn't necessarily been shown to be harmful, although, you got this foreign substance that's kind of sticking around in the brain longer than you thought it was. And if somebody with MS is going to get an MRI scan, say once a year, then that ends up being quite a lot of gadolinium if you're going to be giving it every time. So the general consensus has been over the past few years, if you don't need it, don't get it. But it's not, since it's probably not definitively harmful to people, you can certainly still get it. And so, that's been kind of my rule of thumb, is that, like, if I need it, I'll order it. But as just a kind of routine matter, if somebody's otherwise doing well and we're just probably going to continue whatever course they're already on, and we just want to double check to make sure they're not developing new lesions, then I might just do a scan without contrast. And that's, by the way, contrast gadolinium that we use in MRIs is very different from contrast that you get in CAT scans. And so just because you might have had a reaction to a CAT scan dye, which is actually very common, does not mean that you will necessarily have a reaction to a gadolinium in an MRI. Any new ideas for treating pain and spasms in MS? New. Well, we do treat them. That's not a new concept. We use a lot of different types of medications for those things. Nerve agents, anti-nerve pain agents, pregabalin, gabapentin, duloxetine, venlafaxine, topical things, or anti-spasticity medications, baclofen, tizanidine. I think I gave a talk on the management of this not too long ago, Kelsey. Thank you. Those are not necessarily any of them particularly new. I think, one thing that people often don't realize is that there are other ways of kind of managing pain that are not just primarily like what I as a neurologist can prescribe. So there's also sometimes people will get I guess I could prescribe, neurologists in general could prescribe these things. So things like Botox injections will sometimes be used for people who have a lot of spasticity, especially if it's like very localized in certain areas. And I suspect that there are people who may benefit from those things that are not receiving them because they just don't think about them, or their doctors don't think about them. To a certain extent, baclofen pumps similarly. So people who have a lot of spasticity, that is not necessarily responding to oral anti-spasticity agents like baclofen. Sometimes we'll have a pump implanted, and then the medicine will be delivered directly into their kind of spinal canal, and that can be more effective and actually more better tolerated. You're able to get kind of the drug more where it's needed to go. And then there are other things you can do for kind of refractory pain. There's different type. Again, this kind of goes back to the earlier question about like where's the pain coming from. If it's not nerve pain, maybe you kind of address whatever else you think it might be coming from, or if it is nerve pain but it's not from MS, like if it's coming from a pinched nerve, maybe you talk with a surgeon or a spine person and you do an injection in that area and try to see if you can get some like a steroid injection in the epidural space and try to see if you can get some relief that way. People often forget about the kind of non-pharmacological stuff that can help with pain. So that would be things like acupuncture, massage, dry needling, things of that nature. And I mentioned the topical things, which is pharmacologic, but it's not like a systemic thing necessarily. But there are creams, there are ointments, there are things that can be helpful, especially if it's in a more limited kind of area on the body that can be used. So a lot of things, a lot of options available. Pain psychology is also a new thing that people are starting to discover that can be very helpful in people who are dealing with chronic pain that doesn't seem to ever go away despite medication trials. Some people who with a lot of pain that's not going away from a lot of other things, we might send them to get like a spinal cord stimulator. Some people they have pain, and then they get the stimulator and it just goes away. But obviously that's a very invasive kind of thing. So a lot of options available. Some I guess a little bit newer than others, but nothing that's like super brand new. But there are a lot of options, and I think people don't necessarily take advantage of all of those things or think about all of those things all the time.
Dr. Gross, we did put the links to both your presentations on pain and spasticity in the chat. We'll also include those in the YouTube description. We did have a question on trigeminal neuralgia pain. Their episodes are increasing in both frequency and duration, and they switched from gabapentin to carbamazepine. But if their incidences continue, kind of what's the next step?
Yeah, thank you for bringing that up. So that kind of thing that's kind of paroxysmal or comes in like jolts of pain, that's kind of got a nerve quality, the classic being, of course, trigeminal neuralgia that affects a person's face. We'll often reach for things like carbamazepine or oxcarbazepine that actually were originally anti-seizure medicines, as was gabapentin actually. But I'll preferentially go with those, the carbamazepine, and you kind of sometimes have to push it up to a decent dose to get relief. And then if relief does happen, then often you want to make sure that it doesn't come back, in which case people are usually staying on those medications. And of course, with the appropriate monitoring to make sure we're not causing any side effects. In people for whom that is not enough, there are other kind of more experimental medications that can be tried, often also in the kind of anti-seizure medication class. And then if those don't work, we're sometimes talking to our neurosurgical colleagues about options like gamma knife or other types of procedures that can basically cause damage to the trigeminal nerve, so it stops all of its kind of abnormal firing. And so yeah, and I've had people who've gone through that procedure and have gotten relief where they weren't getting relief before. Sometimes it's not permanent, and they might need to go back again, but but oftentimes it does provide a lot of kind of prolonged relief if the medications are not working. Number 13, when is it important to contact your neurologist about a symptom? How do you know if it's just a normal thing or a relapse? Something new and odd feels like a big thing to me most of the time. It's nothing to the neurologist. I really like this question. Yeah, that's a good question. I mean, I'd say rule of thumb is if it's of concern to you, let us know. I mean, and just because it's not a big thing to us doesn't mean it's not a good idea to let us know. We can make a note of it in your chart at the very least. And that way, if you should bring it up again in the future, we know that, oh, they mentioned this before. Because, memories can fade over time and you might not know. But then if we have, documentation that it's, oh, this happened like, 10 times over the past year or whatever, then that's something that we're going to be, obviously thinking a little bit harder about and trying to address more aggressively. This kind of gets at this kind of concept of, what is a relapse? And, we use that term often, but I think sometimes when we talk about it as neurologists, we don't necessarily mean the exact same thing as when, you talk about it as patients. And I think, I personally would like to retire the term. I think it obscures more than it illuminates a lot of the time. What we're hoping to try to figure out is, are you having some kind of new disease activity, new inflammation in your nervous system that would either suggest that you need to go on a disease modifying therapy if you're not currently on one, or we need to change your existing disease modifying therapy to something else. So that's why, we are very kind of tied into this concept of trying to distinguish, is it a relapse or is it a pseudo-relapse or pseudo-exacerbation? And sometimes we'll use these kind of, heuristics about like, okay, if a relapse is usually more than a day, or a pseudo-exacerbation less than a day, or, a pseudo-exacerbation has to have like an accompanying infection that a trigger. And I think we have a question later on about triggers for flare-ups and stuff like that. So people don't always follow the rules is the bottom line. And I think, it's important to get a lot of details for us to collect, to understand what exactly is happening to you. Has it happened before? Has it happened before in that place, in that same way? Are there clear triggers or things that you're noticing, or, does it tend to happen like in the summertime reliably when you're getting overheated? Does it tend to happen, when you get sick, things like that? I think the time course matters to a certain extent. Usually, yes, relapses that are caused by new lesions that are forming in your nervous system are likely to persist. The symptoms are likely to persist for weeks or months. Whereas these fluctuations that are not caused by new lesions, but are caused by existing damage, where the signal is kind of getting through, and then it's kind of not getting through as well, this day and then the following day or whatever. Those tend to be a little bit more short-lived, tend to have some kind of, systemic factor that's contributing to that, although we don't always find it, like heat or an infection or stress or poor sleep. And so we just try to distinguish between them, because again, if you're having new inflammation in your nervous system, perhaps a different disease modifying therapy is the way to go. If it's an existing lesion that's causing you to have these kind of flare up of symptoms, then nothing that we would do differently from a disease modifying therapy standpoint. We would obviously try to identify if there were any kind of contributing factors and go after those. If it's an infection, we would treat that infection. If it's a question of being overheated, we could talk about different strategies for trying to prevent that from happening in the future. So that would be kind of the way we try to distinguish between those things. But again, rule of thumb, especially if you're kind of new to us and you're new to MS, is let us know if you're concerned about something, and we may send you a message that says like, okay, we made a note, keep an eye on things, and we'll see, and we'll kind of see how things play out. Or we may say, hey, that sounds like something we should see you for. Let's see if we can get you in for a visit, or at least a virtual visit in the near future, so we can kind of go over things in a little bit more detail. And so, if it's a big thing to you, then you would think that you would be okay coming in for a visit. And so sometimes that can be the kind of distinguishing factor. If somebody's like, hey, actually, I think I'm okay, I don't really need, then they're like, okay, well, but we'll make a note of it in either case. And then, we're obviously going to be doing our regular monitoring, and, we're going to be checking things like MRIs and seeing, are we seeing new lesions form while you're on this current treatment or no treatment. And if we are seeing something that we think we shouldn't be seeing, then we might change course anyway. Okay, so interested to hear about new treatments to shrink lesions, hinder growth of future lesions, new treatments to treat pain. Can one take advantage of newer treatments without risking current treatments and the likelihood of a cure in my lifetime? Okay, so we kind of talked about some of these things, likelihood of a cure. Can you take advantage of newer treatments without risking current treatments? That's like one of those questions that's like, if you're talking about enrolling in a clinical trial, for instance, you do sometimes need to be off of a kind of a traditional immunotherapy for some period of time, depending on what the immunotherapy is. Although there are now increasingly, especially when we're talking about drug trials for things like that are these neuroprotective type, putative neuroprotective agents, that you might not need to be off of an immunotherapy. You might be able to continue your current MS DMT and be on one of these things. But yeah, it really depends on the study. And, new treatments to shrink lesions, hopefully we'll get some that will shrink or repair lesions. No, the question I mean is really also getting at, I think, in my mind, what is a good way of measuring whether we're actually doing that? Yeah, it would be great if we were able to compare MRIs and we saw 10 lesions on this MRI, and then we saw 3 lesions on the subsequent MRI, and we said, yeah, look, we made 7 lesions go away. I suspect that's not how any of these treatments is going to work necessarily, at least on the sequences that we typically use for MS. We don't have great ways right now of determining healing in the nervous system based on our current MRIs. We're working on developing better techniques and better markers in general of telling us what's kind of happening, in terms of, are those neurons, are they demyelinated? Are they dead beyond repair? Because it very much makes a difference if, we're talking about a potential remyelinating agent, like, is there still a nerve there left to remyelinate, or is that nerve gone? And because, that is a big issue with some of these remyelinating trials and strategies, is like, if you don't have, if there's been atrophy, if there's been, well, if we see like black holes, which are lesions where there's no nerve tissue, those nerves are usually gone. And so until we can develop other ways of growing the nerves back, then remyelinating is not going to get you anywhere. You need to actually have the wire there to put the insulation on, right? And so So we need to figure out ways that we can measure that more effectively than what we are currently doing. And then what is the lifespan of a person with MS from the time of diagnosis? Okay, yeah, we get this question periodically, and there have been studies in the past that have suggested shorter life expectancies for people with MS. Now, major caveats is that they're older studies. People, over time from the 1900s to now, people have experienced in general, forget MS, people in general have experienced, greater life expectancies, each passing kind of generation. So anything that we have learned about in the past about life expectancy would already be off probably by a number of years. Now, when we talk about the average life expectancy of people with MS, sometimes it's, are we talking about like a mean or a median? So like, I think a lot of people with MS live normal lifespans, but there are some who have perhaps very aggressive or severe forms of MS who live shortened lifespans. And then if you take the average or the mean of those, then you're going to get a shorter lifespan. But it doesn't mean that everybody will be experiencing a shorter lifespan. Some people who have more aggressive forms have a particularly shorter lifespan. I think we're probably seeing less and less of that now as our treatments have gotten better. And so it would be nice to see newer studies looking at that kind of thing. But a lot of times people come to me with a new diagnosis of MS and they're worried about their life expectancy. And I say, well, I don't have a crystal ball, but I expect if things continue as they will get you on treatment and et cetera, but I have no reason to believe you won't have like a fully normal life expectancy. So yeah, that's kind of the issue. It's always kind of a little bit of a fool's errand to try to guess, how long somebody's going to live. I mean, any one of us could get hit by a bus tomorrow, but hopefully we won't, right? What's the next one? I have had MS for 34 years now and want to know about cognitive thinking, or how can a person remember more about conversations that a person has had but forgets and gets frustrated with not remembering. I know the usual protocol is to write it down, but can a person take any of the medications that are featured on TV to help aid with forgetting? Also vitamins, what are the best vitamins that I feel are best for cognitive thinking and energy? So this is a good question. I'm glad somebody brought it up, because cognition is an area that's, one of those things that we don't necessarily talk about as much as I think we should. Cognitive impairment, to some extent, is quite common in MS. It doesn't often, although it can lead to very severe impairments like dementia. Dementia, by the way, is just a term for a cognitive impairment to the extent that somebody needs assistance or is dependent on others. So the most common cause for dementia in this country is, or I think probably the world, is Alzheimer's disease. But other things can make a person demented. If you get hit on the head too many times, that can make you demented. If you have a bunch of strokes, that can make you demented. And then occasionally MS can cause dementia, although we don't often see it get to that extent. Common cognitive symptoms with MS are difficulty processing, like slower processing speed, word recall, forgetfulness, some extent executive dysfunction. So those things tend to be fairly common, and again, usually kind of in the mild to moderate range, or person might not have any symptoms, any cognitive symptoms. That's also fine, and that's great. What can you do about them? Well, there's a range of options that we can do. Sometimes it might involve medications, things like that might be, medicines that will be tried on people with Alzheimer's disease. We might also try for people with MS related cognitive impairment. Things, and this is another one that's kind of like, the pain or the fatigue example, where a lot of things may be contributing to it, and it might be helpful to tease out, what other contributing factors are there, and then maybe try to address those. Especially with so with MS, we will often see kind of people also struggling with sleep disorders, because that can be, and mood disorders, pain. So those things, those can all affect a person's thinking, fatigue, and those all have ways of that we can kind of treat those things. And then if we treat those things, then maybe the thinking gets clearer on its own, kind of thing. Well, not on its own, but it gets clearer as a result. And so as far as vitamins go, we're looking for the perfect vitamin for MS. Believe me, we've been looking, and some of these studies that we've done on potential neuroprotective agents have been on vitamins. The lipoic acid is like a vitamin, it's a supplement. High dose biotin was another one that we've looked at. None of them yet have panned out, but we will keep looking. We will keep looking for a good vitamin for MS. And of course, we usually recommend vitamin D. And we have a lot of patients who take vitamin D. Whether it actually makes a difference, especially in terms of like cognitive function, like it may not do a whole lot, but it may have other benefits. And so we're usually recommending it. It's probably very few side effects. But as far as like any of the other stuff that you might, I don't know what you're seeing on TV, but none of it has necessarily been proven to, work particularly well as far as I'm aware. Do you have information on CAR T therapy? Not a lot of information. As Kelsey mentioned, I think there was a recent talk at our last Ed Summit on CAR T therapy by Dr. Amanda Piquet. So check that out on the website. It's basically, the idea is, so this is in a category of that first category. It's a kind of immunotherapy in a way, but what you're doing is usually, I think, taking your own body's T cells, a kind of immune cell, kind of tweaking them, adding some modifiers, and then putting them back into your body, and those modifiers are then going to go after, in this case, maybe your B cells, another part of your immune system, and try to remove those in a similar way, maybe as something like an ocrelizumab or something would remove B cells, or with the same effect, maybe not in a similar way, but to have the same overall kind of effect. So as far as I'm aware, these have been used to treat other kinds of conditions, not autoimmune conditions, and so they're being studied now in MS and other autoimmune conditions. And Dr. Piquet is doing at least a couple trials, I think, on this in MS and other things at our center. And so if you have information, or if you have, you want more information about that, or if you think you might want to try that in a clinical study, then reach out to our research folks, and there should be the information. And then, again, usual caveat, like, we'll see if it works, right? Well, clinical trials, again, are there to see if something is safe and effective. And so, something may be effective, but it might kill you. Not the saying that this will, but like, obviously that would be a bad outcome. So we want to make sure that our treatments satisfy both of those criteria. And so, hence we do clinical trials. What is Balo's disease and how rare is it? Balo's is not really disease. I mean, it's MS. It's a description. It's a pathological description of MS. Basically, the idea is that it's a lesion where there's like kind of a concentric rings of demyelination and remyelination, demyelination and remyelination. And so if you look at the very old textbooks in MS, they would say things like, oh, it's inevitably fatal. But there was a major kind of bias from that, which is that we didn't really have MRIs back in the day. And so whenever they saw it, it was from an autopsy. So I was like, yeah, it's fatal. Now we see things that we think have that kind of pathology on MRIs from time to time. And it doesn't necessarily tell us it doesn't tell us at all how a person is gonna do. It's just kind of a neat thing that we'll sometimes see. I'm like, oh yeah, that kind of looks like a Balo's. Okay, yeah, it kind of does. But otherwise it's just MS. And MS can be very, variable. It's heterogeneous, and some of that has to do with where the lesions are, how many lesions you have, what your baseline level of kind of reserve or resilience is, and how soon you get on immunotherapies or treatments. So a lot of those factors play a role, far more than like what we think the underlying pathology is, if we were to cut open your brain, which hopefully we won't do. Hopefully you won't let us do that. Thoughts about Ocrevus's effectiveness as a first line of treatment? Yeah, it is quite effective. That's why I use it a lot. Again, especially early on and in the relapsing forms of MS, it tends to be very effective. It and the other anti-B cell therapies tend to be very effective, hence why we use them a lot. Again, in progressive, we're looking to try to find better solutions to slow down progressive MS in people. It is approved. Was the first medication approved as a treatment for primary progressive MS. But again, nothing works particularly well in everybody with progressive MS, and so we need better options in general. But as a first line of treatment, yeah, I like it. And we don't have necessarily like a widespread consensus on first line, second line type things throughout the world of people who treat MS. We as a center and a lot of major academic centers in the US nowadays see it similarly, that no reason to wait until 5-10 years go by and you failed XYZ to go with Ocrevus, because it's really good and you've got a lot of reasons to use it up front as a first line. Not everybody sees it, especially in other parts of the world. There's where a lot of places are still kind of in this kind of escalation mode, like you have to start with the oldest injectable agents, and then if somebody does poorly with one of them, then maybe you up it to like maybe a moderate efficacy medication, and if someone does poorly with that, then you can keep kind of escalating in that stepwise way. Ends up, in my view, wasting a lot of time and using a lot of things that people don't necessarily tolerate that well or are not that effective, and so I use Ocrevus or other high efficacy treatments early on, often. Question number 20. Are sensations like internal hotness / coldness and buzzing common to a flare-up? And then remedy / restore. Meaning like it goes away on its own. Sure, yeah. Abnormal sensations are very common: buzzing, tingling, burning. All that can definitely happen when people have MS lesions, particularly lesions in their spinal cord. So if it doesn't go away right away and it's lingering, then that might be something we would use an agent like gabapentin, pregabalin, duloxetine, venlafaxine for, and then just kind of see how it goes. If we need to increase the dose, we increase the dose, kind of thing. But yeah, those are fairly common. 21. What really helps fatigue besides exercise, healthy diet, sleep, meditation, qigong, and yoga? Well, yeah, all of those things certainly can help with fatigue. I mean, again, kind of fatigue is one of these things where it's quite common in MS, and also other things can cause fatigue. And so if your fatigue is because you're not sleeping particularly well, then we should be addressing that especially. It turns out that things like obstructive sleep apnea or sleep disorders, but obstructive sleep apnea especially, or OSA, is quite common in the general population and then in people with MS. And treating that, for instance, although not exclusively, by using a sleep mask, can actually help people, improve their levels of energy during the day. And so if you haven't had a sleep study and you're suffering with a lot of fatigue, that might be a good thing for you to discuss with your neurologist or with your primary care doctor. And of course, we use a lot of medications, a lot of stimulant medications to help with fatigue. Modafinil, armodafinil, amantadine, dextroamphetamine or Adderall. Yeah, those would be the most common ones that we use. And so yeah, so there's and then all of those things that were mentioned that are very important. yeah, exercise, healthy diet, all of that stuff. And we were joking about this before. I mean, a certain amount of fatigue is natural and normal to the human condition, and so you don't necessarily want to medicate away all fatigue. It's okay to feel fatigued every once in a while, particularly if you had like a long hard day at the office, or if you just did a lot of physical exertion or whatever. And so it's okay to kind of take it easy after that. You don't need to keep pushing yourself necessarily. Now, if you're prone to fatigue, and maybe scheduling in some break times to kind of regain your energy, and then kind of take things from there. I think that's all okay. Our office often helps people deal with kind of getting work accommodations, so that people's employers are aware that this is a thing, and that they need to kind of be mindful of it and allow them to take breaks periodically. I think that's people are starting to realize that that's a thing, and so we're happy to help with that. So yeah, there's different things, medication and otherwise, that can be done for fatigue. So but you have to bring it up. We have to know about it. Or we would ask, hopefully. What would appreciate hearing your point of view on the Mavenclad treatment. My sister's newly diagnosed, considering this option. Yeah, Mavenclad or cladribine is an oral medication. I mentioned it earlier as a kind of an immune reconstitution therapy, or kind of one, in which you take it for certain at certain points for a limited period of time, and then you don't take it anymore. There's like a maximum amount that you can receive, and it basically removes certain immune cells from your body, and then hopefully they don't grow back, or when they do grow back, they don't want to attack your brain and spine anymore. And so yeah, it's an option. I personally haven't prescribed too much of it. I prescribed some of it, but yeah, it's an option among many that you could discuss with your neurologist, or she could discuss with her neurologist, as whether it's a good idea or not. I don't know if I have too many more specific things to say. Again, I don't use it particularly often, so we'll just move on. Talking about smoldering MS. Okay, so smoldering.
Dr.
Oh, yes.
Gross, within this discussion, could you also talk about the difference between an active and an inactive lesion? Is there still nerve damage in both, and how are they manifested in the body?
You mean about the smoldering MS?
Mm-hmm. And just this person was asking, when we were talking about contrast agents and you were discussing active versus inactive lesions,
It
just
also,
kind of a general definition.
yeah, it also goes into this idea of smoldering MS too. So it's not really smoldering MS. Smoldering is like this. So what is it? What is smoldering? Smoldering is like, the fire is like, it's still kind of going a little bit, but it hasn't like erupted yet. So it's a term that we used to call these chronic active lesions. So it's a pathology term. It's a term based on what we would see under a microscope, initially, really, in people who were having autopsies, so no longer alive. And so and now there's kind of more of a buzz about this thing, and we're trying to develop additional tools that we can use to identify these chronic active lesions, and whether they are important or not. They probably are. So an active lesion, or at least an acute active lesion, is usually one caused by infiltrating autoimmune, like autoreactive cells that are going to go in there and then attack your myelin and your nerves. And that's visible on an MRI, usually by the appearance of a new lesion that takes up the contrast, or gadolinium enhancing lesion. A chronic active lesion, that's a lesion that's chronic. It's been there for a while, but it's still active. It's still got some stuff that's happening. So we think that it's got some certain cell types, like activated microglia or macrophages that still contain some myelin debris inside of them that you can see around the edges of these things. And so we think there's still some amount of damage that's happening in a low level kind of inflammation kind of way. And then the trick is just trying to figure out how can we identify these things and ideally stop them if they can be stopped, right? So there are these new MRI techniques that people are exploring. The idea, or one of them being slowly expanding lesions. So like if you look at an MRI and you measure the exact size of a lesion, and then you look at an MRI a year later or 2 years later, whatever, and you measure the size of the lesion then, and if it has grown ever so slightly, then it is a slowly expanding lesion. Please don't ask me to do that on your MRIs. It's very laborious, and for the most part, we're not doing that on our routine clinical MRIs for that reason. But in research studies, they're often able to do that, and they use specific tools to do so. And then another way of doing it is looking at what's called a paramagnetic rim lesion. This is looking at a particular kind of characteristic of a lesion, like whether it contains iron around the rim in these activated microglial macrophages. It turns out that a lot of people, probably more than half of people, have at least one of these paramagnetic rim lesions, and probably more than that have at least one of these slowly expanding lesions. And so we think that you have more of these. Maybe you're more prone to developing progressive MS or progressing faster. That's the idea. And perhaps maybe they can be used as a marker for, treatment response. I don't know that any of our existing medications has necessarily, done a whole lot with any of these, but we haven't necessarily been measuring them either. And so yeah, but you'll hear a lot of buzz and you'll see a lot of things about this, particularly from at conferences, pharmaceutical companies who hope that their immunotherapies will attack this kind of chronic active inflammation. But the reality is, as I've alluded to several times, is that a lot of what is existing in the immunotherapy space hasn't necessarily made a dent, at least in the big picture, in terms of delaying disability progression and so forth. And so, I couldn't say for sure whether your MS is smoldering. I mean, I can tell, how recently you've had a relapse based on what you've told me, or how recently your MRI has shown an acute active lesion. And then whether you're experiencing a slow progression or a slow decline in your level of functioning. So I can tell all those things clinically, but I can't yet necessarily tell you whether there's or to what extent there's some amount of smoldering going on. And even if I could, I don't know that I would necessarily be able to do anything about it at the current time, beyond what we're already doing. I know question 24, I know one study failed to show benefits. Do you believe the process for seeking FDA approval has permanently ended for Sativex? Well, I haven't heard too much about Sativex lately, so I guess I don't know the answer for that. Sativex is like a spray, an oral mucosal spray combination of THC and CBD, so parts of the marijuana plant, the cannabinoid medications or compounds that some people think is quite helpful for managing certain MS-related symptoms like spasticity and pain, things like that. And actually, that product, Sativex, is approved in several other places. I think like Canada, the UK, just not in the US. And I don't know if it ever will be. Yeah, so I don't really have any more inside knowledge on that kind of thing. Of course, if you live in the state of Colorado or a lot of other states these days, you can have a lot of access to lots of different cannabinoid products, and a lot of it is kind of unregulated, we'll say. I mean, we don't have great clinical trial data, for instance, and that has to do mostly with kind of the way that it has been scheduled on a federal level and how difficult studying it can be. I mean, I'd like to see more kind of rigorous standardized trials that looked at this kind of thing. But in the meantime, I hear from my patients, from you guys, that tell me like, hey, I've tried this thing and it seems to help me with this particular symptom, especially again the spasticity or the pain, or sleep sometimes can be helpful for that. Or I hear from people, hey, I tried this and it didn't really help. you know, I say, okay, great, thanks. Thanks for telling me. I won't recommend it to you again in the future. Can the inflammation in your body be controlled? Can the myelin sheath be repaired? Answer to question one, yes. MS-related inflammation can certainly be controlled. You may not be able to control all inflammation in the body, but a lot of MS-related inflammation can be controlled. Can the myelin sheath be repaired? You know, we've discussed this. Your body does have a certain kind of natural repair or mechanisms that, you know, to some extent, having, you know, an MS lesion there, it tries to inhibit those repair mechanisms, but you do recover often. There is some remyelination that happens early on in these acute lesions, but it can be incomplete. And so again, we're looking for that thing that can kind of promote further remyelination. 26, I moved from Montana to Colorado. I'm on Ocrevus and my neurologist is not doing blood work to monitor me. That was always done in Colorado. Should I be concerned and should I request blood work? Yeah. Yeah, you probably should request blood work. We usually do monitor people on Ocrevus with regular blood tests. I'm usually checking once every 6 months and looking for things like blood counts, antibody levels, things like that. So if that hasn't been happening, it probably should be happening. You know, we do have a big just a shameless plug for our center. We do see people from all over, including from Montana. I know it can be a little bit of a trip. We do virtual visits, but me personally, I'm only licensed to practice in the state of Colorado, and so you'd have to physically be in the state of Colorado to do a virtual visit with me. But I see people who live there and they come, you know, once every 6 months or once a year, and maybe they have somebody local that they see in the interim. And so I'm just saying that that is also an option. Or you can just, you know, request some blood tests. Yeah, I think you should do that either way.
And Dr. Gross, I did just want to give you a 5-minute warning if you want to prioritize some questions.
Yes, no, actually, I think we might be able to get to all of them because there's only a few left. 27, what DMTs are appropriate for seniors 60 plus, especially in light of drug test cohorts, generally excluding people in this age range? Yes, thank you for bringing that up. So this is, you know, been kind of top of mind for me lately, as I mentioned before. We don't have a lot of great evidence on what works in people who are older. And I don't like to say, you know, old, because, you know, old is in the eye of the beholder. But, you know, say 60 plus, you know, most of the time our clinical trials are not including people who are over 60. And so, and we know that MS changes over time. And as I've mentioned, it's, you know, the type of processes that are more active early on in MS tend not to be active later on in MS. And so if you're 60 plus and you've had MS for 30 years, what have you, then it's a very different situation and a very different likelihood for response to immunotherapies than somebody who is newly diagnosed and in their 20s or early 30s or something like that. And so, again, not to say that I don't still treat people who are 60 plus with immunotherapies. I do. But I look at those factors like, you know, when was their MS diagnosed? You know, when was the last time the MS was active? You know, what do their recent MRIs look like? Things like that. And, you know, you have to think about different things, like our immune systems naturally kind of weaken as we get older anyway. And so a person who is older, and again, not that 60 is necessarily that old, but, you know, you might think, well, like, hey, maybe I shouldn't push quite as hard, you know, maybe they might be more susceptible to complications like infections, or, you know, they might need to have you know, more vaccinations to protect themselves, and some of our treatments might impair that response to vaccinations. And so I might be a little bit more cautious around certain medications in older cohorts than I am in younger cohorts. So, so that's something else to consider. And then, of course, the topic of, you know, if you're already on treatment, you know, when do we stop treatment? And, you know, I can talk for a long time about that. But the short answer is we don't know exactly. But it's going to involve a lot of those same factors, those same considerations about like how recently was the MS active, how long have you been stable, if you are stable, and what drug we're talking about, you know, that we could stop or delay. And so, And so we're still trying to work out better tests and better kind of guidelines around, how do we safely, what does the exit ramp look like, for people with MS? Presumably, most people should not need to be taking MS medications their entire lives. Is the kind of where we should be, our baseline. How do you graciously age with MS after 25 years? And when do you know when it's time for a wheelchair? Oh, I like the word graciously there. Well, it's not an always easy, thing to tell when either a cane or walker or wheelchair is required. But oftentimes your family is the person that the people that are telling you like, hey, we should really be a little bit more careful. And if you're having a lot of falls or near falls, then that's something to strongly consider. You talk with your neurologist. You can talk with your physical therapist if you're working with a physical therapist also. But often it comes down to like, what is the safest option for you? And, just because you're in a wheelchair, some of the time doesn't mean you have to be in a wheelchair all the time. You can be in a wheelchair for longer distances. I have a lot of people who do that. And then they try to, around the home or just outside the home, they'll do more walking. And so it doesn't have to be an all or nothing kind of thing. But do consider it or some kind of, assistance that you're not already getting if you're having more falls than you should be having, which is really any falls that are not obviously provoked by slipping on the ice or something like that, which you should also try to avoid. Okay, question 29, please review current and future methods, therapies to repair the damage caused by MS. And then here's the AI response. And then they've listed the whole chat GPT response to which, I did talk about this already to a certain extent. We talked about like emerging therapies, things that are in clinical trials that will hopefully be useful for promoting myelin repair. There's a thing about stem cell therapy, which, that's a whole other topic, but, for the most part, that I wouldn't put that in the same category as remyelinating things. It's more of a, that first category, that those immunotherapies, because most of the stem cells that have been looked at so far, and it's still an experimental thing, but most of the stem cells that have been looked at so far for MS have been in the hematopoietic stem cells. So things that cause production, or that kind of reboot your immune system. And so not necessarily going to affect damage that's already existing in your brain or your spinal cord. And so I would really put that as more of like kind of a different type of immunotherapy and not necessarily remyelinating therapy. But I think this is, it's an interesting example for like, internet can get some things right, but it can also get things that are like, I don't know. So always good to kind of go over it with your doctor. And if you want a lengthier response, like, longer than what I've been able to give right now, then, an appointment is usually a good place to do it, as opposed to just kind of back and forth over chats or whatever. And I think that was the last question. No, the last question was about, why does even minimal physical exertion, heat, or stress trigger sudden fatigue and or cognition issues? So this kind of gets back to what I was talking about before, this, notion of, exacerbations or pseudo exacerbations. And, in this case, they seem to be talking about symptoms that they have had, that, issues that they are dealing with, sometimes more present than other times. So this would kind of be more in that, if you want to call it that, pseudo exacerbation category. And there are clear triggers, which in this case, they're saying the triggers may be mild, but the neurological symptoms that result from it seem to be pretty severe and prolonged. And so why does this happen, I guess? It's a great question. And again, the usual teaching is you try to eliminate whatever trigger it is, and then hopefully the things will kind of resolve on their own. That doesn't always happen. And so maybe working with your doctor and trying to figure out other things that you might be able to do, either to shorten that current cycle or to try to prevent the next one from happening, by avoiding triggers as best as possible is usually the way to go. So I think that is a little bit over time, but I was able to get to all these questions. So thank you very, very much for listening. Hopefully it wasn't too boring. And I think, Kelsey, it's all going to be online, right?
Absolutely. Thank you, Dr. Gross, for your time tonight. Thank you, everybody, for your questions and for being here. The recording is going to be on YouTube within a couple of days. And then I did just want to mention as well, we had a lot of interest in research topics tonight. Our latest issue of Informs, which will be in mailboxes any day now and is available on our website already, it covers a lot of research, particularly from the ECTRIMS conference that just happened. And then we also, our last issue of Informs covered some research topics, including stem cells. So if you want a longer explanation there. And then we also, Dr. Corboy has done a lot of work and presentations for us on the discontinuing trials, but also just a good discussion of MS DMTs over a lifetime. And that is also on our YouTube channel and mscenter.org. So thank you all again and have a lovely rest of your evening.